to understand clearly, so that you this will contribute to your outcome. The main subject of the talk is what to expect, when to expect it. Also, expectations are high, and we want to have you understand why our expectations are high. So I'm going to give you an insight as to where the Oasis of Hope medical staff gets the license to continuously encourage you, to continue. How come we're so sure you're at the right place, you're doing the right therapy, and you can expect to do very well? So this also includes somewhat of a historical perspective of the Oasis of Hope, because I have been here for 32 years, and I can give you an insight as to the Oasis of Hope before and the Oasis of Hope after. After what? We'll get to that. So we'll start with the latter point. How come? Where do we get the license to encourage you? How come we work hard on that? There's a very large body of medical research that indicates that whatever is here and whatever is here is going to contribute to your outcome. So, we want your expectations to be here. But smart people, people with good judgment and good discernment, are not going to set up their expectations on the basis of illegitimate reasons or illegitimate causes. Such as, some of our patients, unfortunately, have been victims of what we call unnecessary roughness. How does that work? Well, some patients who are in good condition, who have good therapeutic perspectives, might be told to go and take care of their affairs, that there's nothing else they can do, that they're terminal. And some patients allow that to take hold in their minds, in their hearts. This can be quite difficult to dispel. Most of our patients are very successful in not buying into that, because when the doctor says something of that nature, he's only referring to therapies that he may give you. He's not referring at all to any therapy that you might get outside of the box, so to speak. So most of our patients understand that very well. Again, that's good discernment, that's good judgment, that's intelligence, that's doing your homework. Most of our patients do that, but some patients allow these gloom and doom assessments to take hold in their mind, to take hold in their heart. And so they will not react very well to encouragement. In fact, you can see it written on their faces. These guys, they're just full of wishful thinking, hopefulness. Maybe they're just really good at cheerleading. Picture me in a cheerleader suit. That wouldn't work. Or as we've heard for decades, they're giving you false hope. They're giving you false hope. So, none of that. The rationale as to where we get the license to encourage you is what I'm going to explain to you, so that you understand. So if you are carrying that unnecessary baggage, unnecessary load of having allowed a gloom and doom type situation to take hold in your mind, take hold in your heart, the following is meant to help you dispel that. As I mentioned, There's a very large body of medical research that indicates that whatever is here and whatever is here will contribute to your outcome, either positive or adverse. At the Oasis of Hope, we are firmly convinced that the best explanation as to why we're able to help a high proportion of our patients is the integrative approach. We're attacking cancer on multiple fronts. We're not allowing cancer a balance. We're always keeping cancer off balance with many elements of therapy. And you know what's a very good contributor to that integrative approach? It's your mindset. It's your emotional, spiritual, physical situation. So we want them to be optimal, because if they are, then you are adding a very important element to your treatment bunch, to your treatment team. And in cancer, every little bit helps. That's why we're doing multiple elements of therapy. If you take one of our therapies outside of the group and you do it by itself, it's probably meaningless. But if you're doing it as an integrative approach, a synergistic approach in which all therapeutic measures are working with each other and for each other, then we get the results that sometimes or very frequently are beyond the reach of chemotherapies and the like. So, again, going deeper into this point, if you ask any cancer practitioner, what's the toughest cancer to treat? What is the toughest cancer to treat? There are so many. The answer to that question will likely have a lot to do with that practitioner's own experience. Recall, because you always remember your great failures, just like you remember your great successes. And I can tell you that there's a cancer type that we had, that it took us 25 years. Remember, I've been here for 32 years. It took us 25 years to get a single case of a positive response in this type of cancer. A cancer, if you ask me what's the toughest cancer to treat, my answer would be the uterine sarcoma. Over the long history of this hospital, which I've been part of for 32 years, this disease, which is fortunately not a very common condition, every year we would get 1, 2, or 3 cases of this disease.
Oh, the second one.
And the result was total failure. We were not able to help anyone with this condition. So over time, that was very apparent. We considered them, we would call these cancers bulletproof cancers. Bulletproof cancers, because this type of disease is resistant not only to orthodox measures, but also to alternative measures, and they typically represent a very short-term death sentence for anyone unlucky enough to have this cancer. However, remember, everything I'm saying to you right now is meant to be encouraging to you, because there's another side. Yes, it took us 25 years to get a single case of benefit for that case, and up until then, every time a patient would call as a prospective patient and I would see that the diagnosis was uterine sarcoma, I would actively try to dissuade a patient from coming to the hospital. Try to give them good medical reasons why they should not come. And obviously the main reason was, well, we've never been able to help anyone with that disease. And so I'll give you some examples. Just not only did we fail to help our patients, but they represented some of the most dramatic, some of the ugliest cancers or cancer behaviors that we have seen over the years. So I'll give you some examples just so that you have a mental picture of what I'm referring to. A young lady comes to the hospital having recently been diagnosed with a uterine sarcoma, and she has a physical examination on admission, and the tumor is felt at the level of the navel. As you know, the uterus is as you may know, the uterus is a pelvic organ. You cannot feel it by touching your abdomen because it's an organ which is below the bikini line. You can only feel it by doing a pelvic examination, a vaginal examination. And so, on admission, her uterus had grown up to the level of the navel, which corresponds to about a 4 to 5 months pregnancy. About a week later, after her admission, when I did an examination, I felt the tumor to be well above the navel, a good 2 inches above the navel. So I mentioned that to the admitting doctor, and I told him, I think you made a mistake with the measuring of this tumor because it is clearly above the navel, a good 2 inches. He double checked and he agreed with me, and he corrected the file, and we thought nothing of it. However, this patient was getting progressively sick. Every day she got worse. Her tummy was swollen. It was tight. She was extremely uncomfortable, and she appeared very ill. And so I can remember feeling her tummy, and I felt something up here at the pit of the stomach. And I remember clearly that I asked myself, I wonder what that is. Certainly not cancer. Cancers don't do that. We're talking a 3-week treatment stay. We're talking a week after admission, a little more than a week after admission. So we did, because the patient was getting so sick, we did something that we rarely, if ever, do. And pay close attention, because this is an answer to one of the most frequently asked questions by our patients. Doctor, are we going to do a second scan at the end of my stay? A second PET scan, CT scan, MRI, whatever is required to evaluate a response? Are we going to do that after the end of 3 weeks? The answer is no. 3 weeks is just enough for us to figuratively plant a seed that we expect will grow into therapeutic success. Our treatment requires 12 weeks after discharge to be evaluated for results. Interval results do not count, and I will get into that further as we go. But at the end of 3 weeks, not that some patients might not have already improvement, but that's not the rule. Sometimes it's totally the contrary to that. At the end of 3 weeks, all we've done is to plant the seed of success. So no, we're not going to do a second scan. As you all know, everyone gets a baseline test, a pre-treatment CAT scan or image test. So at the end of 12 weeks, we do repeat the test, and then you show them to you side to side, so you see exactly how much you benefited from the therapy. But not after 3 weeks. Our treatment requires 12 weeks after discharge to be evaluated for results. That is the minimum period that this treatment requires to be considered fully tried. But getting back to the patient I was describing, she was getting very sick, progressively sick. So we had to do another CT scan and find out what was going on. So on that second CAT scan, what we saw was that the tumor that was originally around the level of the navel was now at the pit of the stomach. It takes a pregnancy about 4 to 5 months to get from the navel to the pit of the stomach. And that's fast-growing tissue. It took this cancer 2 weeks to get from here to here, which is monstrous behavior. I can remember thinking to myself, all that's needed right now so that lady's tummy was going to open up and out comes an alien, just like in the movie. It was one of the worst cancer behaviors that we have seen. Needless to say that the patient did very poorly, and she didn't even leave the hospital. She died here because of such an aggressive nature disease. A second case, just so that you have a mental picture of what we went through for good 25 years. And I'm not even going to get into the childhood cancers and all of that, because there is childhood sarcoma, etc. If I do, I'll break into tears. Second lady comes into the hospital. She recently had surgery for a uterine sarcoma. She had her uterus removed, and she developed a recurrence, a tumor recurrence, soon after. And this tumor recurrence was located at what's called the vaginal stump. The vaginal stump are the vaginal walls sewn together. The uterus was here, and the vaginal walls, the front wall and the back wall, they go around and over the uterus, the uterine cervix. And so when you have a hysterectomy, that gets removed, and the cavity that's left is sewn up. So the vaginal walls are sewn together, and that's called the vaginal stump. She developed a recurrence at the vaginal stump, which was growing down into her vaginal canal, growing downwards. On admission, it was necessary to do a pelvic examination, a vaginal examination, to get a clear picture, to get a good idea of the features of the disease, consistency, size, etc. Well, not to make the story very long, at the end of 3 weeks, it was no longer necessary to do a vaginal exam, because now she had a cancer which was protruding across the vaginal inlet like a big bloody cauliflower. Again, in less than 3 weeks. And I could go on and on about the horrible experiences that we have had with this disease. So no wonder we would not want to deal with it. One of the last patients that we treated for this disease was a lady who also had surgery for a uterine sarcoma. She developed a recurrence at the vaginal stump, but this was not growing downwards into the vaginal canal as the previous patient. This was growing upwards into the abdominal cavity. So on the PET scan, she had, right where her uterus used to be, at the lowermost part of her pelvis, she had a tumor, which was a big round tumor that was it was the size of a large grapefruit. And if you know about PET scans, you know that the software in PET scans will paint a tumor bright orange or yellow color. So literally that looked like a large grapefruit in her lowermost pelvis. So we started doing therapy, and I was extremely concerned. I was very preoccupied, and going back to my recall, I was fully expecting for this patient to give us another horrible memory. But the patient went through the treatment well. Uneventfully, she did fine. And so I was happy to see her go in good condition, but I thought to myself, yeah, but that's a uterine sarcoma, so she'll probably be calling pretty soon on the follow-up phase of her therapy, that is the home treatment phase, and calling us to tell us what horrible things are happening to her. She came back 3 months later, having done her treatment, or home treatment, rather uneventfully. She appeared well, she looked well. So we were very anxious to see on that scan what were the results, what the comparison results were. So we did that second PET scan and compared them side to side, and the very large grapefruit sized tumor that she had on her baseline test was now a small orange, which may not sound like a big deal to you. But after 25 years of not a single case of therapeutic benefit against this disease, now we had a treatment response which was indicative that our treatment had become stronger, had become improved and refined. That was a function of the addition of the dendritic cell vaccine into our integrative approach. A very strong immune stimulatory therapy. If it were one case, I would still be here bragging about it because these cancers are that difficult to treat. But it's not one case. We have now, our treatment has now registered good responses against, not only against this disease, but sarcomas are a family of cancers. And they're all bulletproof. There's the uterine sarcoma, as I described. There's the muscle sarcoma, the bone sarcoma, the soft tissue sarcoma, the liposarcoma, blah, 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 blah. They're all very difficult cancers to treat. They're all bulletproof. And our treatment has now registered positive responses against multiple members of this terrible cancer family, where before we had absolutely zero response. So, what do you think that does to the degree of confidence that the medical staff at Oasis has on the therapy? Where before we had no success against what we consider the toughest cancers around, now we have a treatment which is up to the task, is strong enough to deal with the absolutely worst types of cancers that there are. So why am I telling you this? I started the conversation by telling you that I would give you an insight as to where the medical staff at Oasis it gets the license to encourage you. From Dr. Contreras on down, you will hear nothing but encouragement from us. It's like the old song, Home on the Range. Does anyone remember that song? Anyone? Home on the Range? There's a line in that song that says, never is, I would sing it to you, but it won't come out right. Never is heard a discouraging word in the home of the range. Well, at Oasis, it's like that. You will not hear a discouraging word from us because we know that our treatment is up to the task, has the potential to deal with the very worst cancer situations. So what do you think that does to our ability to license to encourage you? Our rationale is, if our treatment is strong enough to deal with the worst, the very worst cancers that there are, and that's proven by 25 years of continuous failure and continuous horrible biological behavior from a cancer. If it's up to the task of dealing with the very worst types of cancers, it's certainly up to the task of dealing with these other cancers. I called the previous one bulletproof cancers. I'll call these other cancers a second group of disease that we deal with. I'll call them, for the sake of reference, I'll call them garden variety cancers. As that name implies, garden variety cancers constitute the great majority of cancer diagnosis. 80 to 90% of current cancer diagnosis is a type of cancer called adenocarcinoma. A word which may sound very familiar to you because most of you have an adenocarcinoma. Adenocarcinoma is a Greek word which has two components. Adeno, which means gland, carcinoma, which means malignancy. So together, translated, it means a malignancy which has risen from glandular tissue. Glandular tissue. Adenocarcinoma of the thyroid, adenocarcinoma of the lung, of the breast, of the stomach, of the colon, of the ovary, of the prostate, etc. All of these share in their origin. They arise from glandular tissue. Now, among these adenocarcinomas, there's a very wide variety, a very wide a gamut of biological behavior. Over here, we have cancers which are as difficult to treat as the previously mentioned bulletproof cancers. Very, very tough cancers to treat in any setting. Over here, we have some cancers which are highly treatable, highly manageable. Some of them are actually highly curable. Quote unquote, nice cancers. But even among the nice cancers, there are situations, settings, that make these quote unquote nice cancers as difficult to treat or worse than the previously mentioned bulletproof cancers. What are those? Number one, multiple treatment failures. A patient is here at a point where they've had 3, 4, 5, 6 or more different types of chemotherapies. Chemos that were partially successful, chemos that didn't help at all, chemos that made things worse. So, by the time the patient is here, they usually have two big problems. One, overwhelming cancer, massive tumor loads. And two, a very poorly functioning immune system, as evidenced by a low white blood cell count. This is a result of multiple damage to the blood, white blood cell producing organ, which is your bone marrow. As you may know, if chemo doesn't help, it'll just make things worse, because each time it fails, it lessens your ability to keep fighting the cancer. So patients who had that history, we knew were very poor candidates, or very, very poor candidates for benefit from the Oasis of Hope therapy. They usually would be people who had 5, 10, 20%, 30% of a normal white blood cell count, because their white blood cell count had been decimated. And they come here with a low white blood cell count and sometimes massive tumor loads. So, the white blood cell count is a very good reflection, indirect reflection of your immune status. If your white blood cell count is low, you can safely say that your immune system is weak or even non-functional. According to us, during that period of time, it was non-functional because we couldn't help people who had low white blood cell counts. They would follow the previously mentioned bulletproof cancers. They would typically follow the expected course of treatment failure. Not as dramatic as the previously mentioned cancers, but failure nonetheless. And it's not difficult to infer or guess why these patients were poor candidates or to get a good response. You come to the Oasis of Hope to do a treatment which is strongest feature is immune stimulation. If you don't have an immune system to stimulate, well, you're in a very difficult situation. And again, the course of our patients, would follow the expected course of treatment failure. However, parallel to our success against the previously mentioned bulletproof cancers, some of our patients with assumed, and I underline assumed non-functional immune systems responded to therapy in a very unexpected manner, which further strengthens our impression, our conviction that our treatment had become stronger, much more up to the task of dealing not only with the toughest cancers, but some of the toughest cancer settings, such as immune suppression or immune deficiency. It also taught us a couple of things. Number one, our immune system is very resilient. We don't need the 10,000 units of white blood cells that we have. 4,000 to 5,000 white blood cells per milliliter of blood is our normal is our statistical norm. These patients with lower counts responded just as well. So that taught us that it wasn't that immune system was not working. It taught us that we did not have the proper immune stimulatory tool, which turned out to be the dendritic cell vaccine. So even at lower counts, our ability to help our patients remain, and patients who historically we would not be able to help were now good candidates for therapeutic success with the Oasis of Hope therapy. It also taught us another thing. Keep this in mind. Functional reserve, resiliency. Our Creator made us with a lot more organ function that we need to live. That is, we can live a normal life with about a half a lung. We can live a normal life with about half a kidney. We can live a normal life with about 1/6 of our liver. That's called functional reserve. And so, when these patients had about 25% or less of their normal white blood cell count, that didn't mean that it wasn't working. It was working and did very well if properly stimulated, which turned out to be the proper stimulus. The proper therapeutic weapon was the dendritic cell vaccine, now in conjunction with an integrative approach, which allowed us to allowed our ability to help our patients in all types of cancers, in all types of settings, to go like this. So, again, I'm telling you this so that you understand why you will never hear a discouraging word at Oasis. In our mind, our treatment is strong enough because we've seen it work in similar or worse situations. It's strong enough to deal with the toughest cancers. It's strong enough to deal with the toughest cancer settings. It's not wishful thinking. It's not hopefulness. It's not undue optimism. It's not false hope. It's track record. The rationale is, we did it before. We can do it again. Every time I see a patient and I get to understand what his situation is, what his history is, what his present status is, what his extent of disease is, almost immediately will I recall 1 or 2 or 3 or 4 or more patients in similar or worse situations that they did well on the therapy. So the logical next thought is, why shouldn't this patient be the next one on our success list? That's the way we think. So it doesn't matter how bad your situation is, because at the Oasis of Hope, your prognosis is not based on your diagnosis. It's not based on your present status. It's not based on your treatment history. It's based on responsiveness. And we have a treatment which is a very powerful weapon against any cancer. So again, high expectations are not only allowed, they are encouraged, because our treatment is up to the task in the worst types of cancers or types of cancer situations. We've seen it work, and that's why you will always hear encouragement from us. We will consider you an excellent candidate for a therapeutic response unless proven otherwise. We're not doing miracles. But let me tell you, there's another situation that impressed us in regards to ability to our treatment. Remember when I mentioned functional reserve? If you go under the threshold of the minimum requirement of organ function to sustain life, that is, you don't have 1/6 of your liver. That is, you don't have half a lung. You don't have half a kidney. So now the patient can't breathe, can't eat, can't poop, can't produce urine, can't clear their urine, can't eliminate any toxins. These patients are in the true meaning of terminal. The word terminal gets thrown around a lot. You're terminal. Go and take care of your affairs. But I feel fine, I feel good. So why are you being told that you're terminal? Because the doctor does not have anything useful to offer you. He's already tried what he has and it didn't work, so his natural assumption is that go and take care of your affairs. And he'll give you the gloom and doom prognosis. That's not terminal, because a lot of people then might come to the oasis of hope and turn it around. That's not terminal. What is terminal? Terminal is once one of your organs or several of your vital organs have failed and are not able to maintain. They do not have the proper function to maintain your life. Strictly speaking, you're not dying of cancer, you're dying of vital organ failure. Respiratory failure, liver failure, kidney failure, etc. I've seen a couple of patients on that stat, literally taken from the jaws of death. If there's anything close to a miracle that might be called a miracle, I would call those. But again, we're not doing miracles, we're doing medicine. Miracles do not require white coats, big buildings, needles, IVs, and all of that. It's medicine. That's why it's not, we're not doing miracles, but we do have high expectation that our treatment is up to the task to help you, and we expect you to be the next one in our success list. So everything you've heard up till now, again, is meant to give you intelligent people, you people with good discernment and good judgment, give you the needed information so that you can set up your expectations up here. Not based on illegitimate reasons, wishfulness, hopefulness, undue optimism, etc., false hope. Track record. We've done it before. We can do it again. We expect that you're the next one. Questions? Anyone out there awake?
The immunotherapy, is this the most recent good thing?
A lot of refinements since we started using the dendritic cell vaccine.
Mm-hmm.
Even it has been refined so that we're using it in situations, and getting success in it in situations where you wouldn't expect that. So, what might otherwise be termed as a miracle, and again, it's not a miracle, it's medicine, is well within the realm of possibilities for this treatment, of capabilities for this treatment. A 100% response on stage 4 multi-site disease, a 100% response on the PET scan is not a rare occurrence at the Oasis Hope. It's not a rare occurrence. So it's within the realm of possibilities for this treatment. So that's why your expectations should be high, because the treatment has the capability. So that's why we will not close the door to any patient. We won't underestimate the difficulty that a situation presents, because obviously the earlier, the better shape a patient is, the better the likelihood of therapeutic benefit. But again, your prognosis is not based on your status or treatment history, it's based on responsiveness. Some of the worst cancers on paper respond very well to what we do. And the opposite of that is also true. Some of the cancers which on paper should respond very well do not. So, but again, the track record against all types of cancers is good enough so that we're sure that high expectations are very much allowed. Any questions? Everything I've told you is again meant to encourage you to set your expectations up here where they belong. And remember, it's not just the value of encouragement. The key to beating cancer is multiple elements of treatment working together, and that includes your mental, spiritual, physical status. If you're able to dispel the fear, the concern, the baggage, you are adding a valuable element to your treatment team. So you're being told all of this so you can believe, so the expectation of a good result is not something that might be taken with a lot of reserve or a lot of doubt. It is within the realm of possibility for you to get the best possible response. Now, I could go on and on here about the excellent shining examples of therapeutic success that our treatment has given until not just a few of you were asleep, but all of you. But there's a source of encouragement which is way better than anything us doctors can tell you. Does anyone know what I'm talking about? Way better than anything that us doctors can tell you in regards to encouragement, in regards to expectations, high expectations. Does anyone know what I'm talking about? Really? Well, if you don't know, it means you haven't taken advantage of it. It is your fellow patient. Almost a constant at Oasis is the weekly visit of people who have been here before, who were here in similar or worse situations to yours, and are now back with an excellent experience to relate to you. A big smile on their face and happy because they have had therapeutic success. And when you meet one of these patients face to face and get to understand their experience, and you tell yourself, wow, this patient is very similar, or this lady or gentleman is very similar to my case, or even worse, and look at them, they're doing well. And they heard all of that gloom and doom. They were all told that, and it turns out that they are beating all of the bad prognostic assumptions. So don't miss the opportunity to help yourself with one by interacting with one of our former patients who's here in good condition, and you'll find that encouragement. That typically allows you to have high expectations, and our returning patients are usually very willing to share the joy with you, because they've been told if they don't, they will be charged extra. So everyone's trying to avoid the extra charge. Right, Mr. Westerman?
Is there?
Yes. So I'm not sure about you, but we got the cameras on you, okay? Very good. Next part of our talk. Any questions? Next part of our talk. Everything I've told you so far is for you to put your expectations here. The next part of our talk may bring your expectations down very quickly. Very quickly. To the point that, a patient might be saying things like, I better call my oncologist and make an appointment for chemo. Too bad. Because it seems to be working for everyone, but not for me. So what could possibly lead to that conclusion while you're here on therapy, or even while you're at the home treatment phase of your treatment phase, that might make you drop your expectations and probably want to go run to your oncologist. Anyway, the shortest answer to that is that our treatment is not a feel-good therapy. It's not a feel-good therapy. There's no relationship between how you feel on the therapy and how you're expected to do on it. It's not a feel-good therapy. So if you're gauging yourself by how you feel in the therapy, you run the risk of saying to yourself, it's not working, something's wrong, because I don't feel very well. Our treatment possibly will cause new symptoms or worsening symptoms, which might actually make you think that you're not doing well. That's why you have to remember that there's no relationship between how you feel and what is expected in regards to therapeutic results. No relationship. They are independent of each other. Some of our most shining examples of therapeutic success have been people who've had the roughest courses. People who were just about to give up on coming back because they didn't feel well through the course of therapy. So why might that be? Does anyone remember what was the factor that allowed our results, our ability to help our patients, not only against the bulletproof cancers, but the patients with assumed non-functional immune systems and all other types of cancers? Our ability to help our patients went like this. Do you recall what factor was that? Anyone? Who wants a free coffee enema? I'm just joking, because some of our patients are going down to the medical desk and saying, I win a coffee enema, a free coffee enema. Just trying to hook your interest. The vaccine therapy turned out to be a very potent immune stimulation therapy. And it so happens that immune stimulation means strong and forceful immune reactions. Strong and forceful immune reactions. Many people think that cancer is a disease of an immune system that doesn't work very well. It's not. Most patients, or let me put it this way, why do young people, otherwise healthy people, get cancer? And they can get tested in their immune systems and they don't find anything wrong with it. It's not that their immune system doesn't work, it's that the cancer is able to fool your immune system, is able to fly under the radar. It goes undetected. So your immune system is not responding against the alien on board, so to speak. Your immune system is just like the cops at the coffee shop, at the donut shop. No alarms are going on, they're just eating donuts. So here comes the pasty. A cancer is growing merrily unopposed. Here comes the patient to the oasis of hope. Even from the first vitamin C infusion. Vitamin C to interact with oxygen to produce hydrogen peroxide, a very potent oxidative agent, which will oxidate a cancer to death. But more specifically, a cancer which has like a invisibility cloak, invisibility mask, is masking, is mimicking a normal cell. And your immune system, which the front element of your immune system is your dendritic cells, or are your dendritic cells. Cells with long extensions, like feelers, like an octopus. These are called dendrites, feelers. Dendrite is a word that comes from the Greek word for roots. So it's like they had long extensions as roots. And their function is to go over your body fluids and tissues and feeling, with their feelers, feeling for anything that does not belong there. They'll identify elements that are part of you, and they will also identify invaders, such as a bacteria, such as a virus, such as a parasite or a fungus. As soon as they identify it by feeling it, they will, so to speak, like a police artist, draw up a very, very clear picture of the perpetrator. And what happens then? They give it to the policeman. And now they know who they're looking for. And that's the same relationship between dendritic cells and natural killer cells. Killer cells, the gun-toting elements in your immune system. But killer cells will not kill anything unless previously instructed by the dendritic cell. That's why they're called the professional antigen identifiers, because they will recognize an invader, an alien. They are charged with recognition, and natural killer cells are charged with killing it. What happens when you hit a wood splinter or a bee sting in your finger? What happens?
Swells up.
It gets red, right? It swells. It gets tender. You can't bend it because it's swollen. You can't put your hand down because it'll throb. That's a good example of your immune system reacting in a very forceful manner against an invader. What invader? Well, if there's a breach in your skin, the millions upon millions of bacteria which are in your skin will try to invade into the bloodstream. And your immune system reacts to seal the area. And that calls for an inflammatory response. And what you see in your finger is very forceful, is very vigorous, and is life-saving. Oh, saving my life for a wood splinter? Yes. Because if your immune system did not react in such a manner to make sure that no bacteria escape into your bloodstream, soon, if even one bacteria escaped into your bloodstream, soon you would have millions of bacteria populating your bloodstream, which is a condition called sepsis. It's a blood-borne infection, a very serious condition, which can lead to an even worse condition, which is called septic shock. So if your diagnosis is septic shock, your chances of dying are around 90%. Doesn't matter what hospital in the world you are, as good as they may be, if your diagnosis is septic shock, your chances of dying are very, very high. And all because a little bacteria escaped from your finger. What does that have to do with you and your Oasis of Hope treatment? The same mechanisms that are at play in the finger. You had inflammation, you had redness, you had pain, which were life-saving. The same mechanisms that are at play to save your life against the escape of bacteria into your bloodstream are now going to be at play against the cancer. Exactly the same mechanisms. White blood cell activation. The white blood cells, once they become activated, they produce substances which are called vasodilators, which means that the blood vessels will increase in their diameter from, say, for example, a garden hose to a fireman hose. What for? More circulation, more blood. What for? More white blood cells, more soldiers, more policemen into the scene to make sure that the area is sealed and your life and health are preserved. The same mechanisms that are at play and the finger are now going to be at play against the cancer, where before they were not. Hypothetical patients, two patients, hypothetical patients, they both have a large outlying tumor, visible, palpable tumor here in their chest area, a very common situation with our breast cancer patients. We start doing therapy and suddenly that tumor gets a red halo. It looks congested, a red congestive halo. It hurts. It wasn't doing that before. It bleeds. It wasn't doing that before. It looks meaner. Doctor, look at this. This is getting worse by the minute. I better call my oncologist and make an appointment for chemo. Too bad. It seems to be working for everyone, but not for me. Another patient in the same situations looks at all of that and understands that these are signs of immune recruitment. These are signs that your immune system has been activated against the cancer, sensitized against the cancer. So instead of looking at that and saying it's getting worse, she's gonna say like, look at this. My immune system's already kicking this cancer. And that is the case. An inflammatory response is a precursor to cancer being gone. And that sometimes has the price of pain or new symptoms or worsening symptoms. But that lady knows that that's not cancer worsening. That lady knows that these are signs that the treatment is working. And where do you think her expectations are going? They're going up because now she has actual evidence that the treatment is working for her. But what if you don't have an outlying tumor? What if you have internal tumors, like it's more common in all of our patients? Spots in your lungs, spots in your liver, spots in your bones. Hypothetical patient comes to the hospital having been diagnosed with metastatic disease to his lungs. This patient has 50 walnut-sized lesions in his lungs. 50 walnut-sized lesions in his lungs.
Yeah.
Let's say 25 on the right and 25 on the left. And the patient feels fine. He looks well. Doctor interviews him. I'll make an example. Do you have any physical complaints? No. Any coughing? No. Any shortness of breath? No. Any symptoms? No. If my doctor didn't tell me I have cancer, I wouldn't even know. Now, how can someone who has 50 lesions in his lungs not feel a thing? And I already answered that question. I'll give you a tip. I answered that question when I spoke to you about functional reserve. Question again, why does that patient does not feel a thing? This is a quiz so that they'll know if you've been paying attention or not.
Because he has enough reserve to not notice the problem.
Functional reserve. We can live with about half a lung. So if you put together 50 walnuts, they don't constitute a very large space. So his lungs, which are otherwise normal, don't feel the restriction. He has enough reserve to feel normal. So the patient, we start doing therapy for the patient, and soon, remember the finger. Remember the finger. What happened in the finger?
Inflammation.
You get inflammation. So pretty soon, the immune system's been turned on because your immune system is either on or off. It's either active or inactive. So, these walnut-sized lesions are now subject of immune attack. The mechanisms that are operating in the finger are now going to be operating against the tumors. So these tumors are now going to develop a three-dimensional inflammatory halo. So they're no longer walnut size, now they're orange size. And there's a big difference between 50 walnuts and 50 oranges in your lungs. How do you think your patient will react in that manner? Will experience the activation of his immune system? How do you think he'll experience that? You can guess.
Trouble breathing.
Doctor, when I came in, I felt fine, and now I need oxygen, which is extremely disquieting. But it's not a sign that the cancer is worse. It's only a sign that your immune system is attacking the cancer. That increase in diameter from a walnut to an orange is not because the cancer grew. It's because your immune system is now surrounding it. Much like in the finger. Remember how that got inflamed and large? Same mechanisms are at play. So now the patient has less breathing spaces and will feel it.
Will that show up on?
It does. That's a big point. That's a big point because remember, does anyone recall how long we need to try our treatment to be considered fully tried? Does anyone remember that?
12 weeks.
12 weeks. Are you sure? It's not 3 weeks?
Pretty sure
It's
you
12
said-
weeks. What happens in the interval? You could get an inflammatory response, and on a CAT scan, that could appear like worsening disease. If you forget this talk, you're gonna run to the oncologist because something's wrong. I don't feel very well. I'm not feeling better. The treatment must not be working. So you go to the oncologist, it's only been 4, 6, 7 weeks since you left Oasis. You're not feeling very well, and you forgot that there's no relationship between how you feel and how you are expected to do on the therapy. And then you go with the oncologist, he'll be only too happy to do another CAT scan for you. And this might show the inflammatory response. He doesn't know what therapy you're doing or care. He's just going to say, look, they look worse. That's what's called pseudoprogression. Pseudoprogression is not a term that we made up. It's a term that's used in mainstream oncology. For people who are doing therapies that involve your immune system, it used to be that all was available for cancer was chemotherapy. Chemotherapy does not involve your immune system. Nowadays, the newer drugs do involve your immune system. The target therapies, the immune therapies, they do involve your immune system. You will get an inflammatory response, and the doctor knows that. So when he checks for you after 3 or 4 rounds of the treatment he's doing, and your tumor or tumors appear to be up to 25% worse, he's going to score you as a positive response. What do you mean I'm doing well? They're bigger. They're 25% bigger. You're allowed up to 25% apparent worsening because of the inflammatory response. This is a temporary phenomenon. Pseudoprogression is likely to reduce over time, which is why we want to check at 12 weeks and not at 6 weeks when the inflammatory response is at its peak. And when you may be misled into, the doctor tells you, see, they're worse. So let's go to chemo. And now you've fallen into an even bigger trap. You've fallen into a pit that now you're going to go to chemo and you're going to tear down everything you've been doing up till then. And you're going to negate the effects of the Oasis therapy because you did a premature evaluation, because you forgot that there's no relationship between how you feel and how you're expected to do on therapy. At 12 weeks, everything that we gave you is now working in synergism. The vaccine, which is the more potent element in our therapy, which is a treatment in itself, is not something that works immediately. It's like a seed. It's like we've given you a little platoon of drill instructors, sergeants, who are training a battalion, which turns later, when the vaccine, the immune stimulation is now being transmitted cell to cell to your millions of immune cells. That's a process that takes time. So over time, your army gets bigger and bigger, your immune army. From a battalion to a brigade to a division to many divisions to an army to many armies. That takes time. It's at 12 weeks when we assume that the vaccine has had a chance to build that army, build that response capability, not before. At 6 weeks or thereabouts, you may be at the point where the inflammatory response is at its worst. And you might easily interpret that your treatment is not working for you. So you wanna make sure that you don't forget these points, because if you do, you're gonna just load yourself with a lot of more baggage, more weight, and your expectations will drop, and that's never a good thing. And if you're still, if you're still haven't been able to raise your expectations up where they should be, don't worry too much about it, because I've seen people who were dragged here to do well on the therapy. Any questions? Yes.
Do you notice any relationship in symptomology between folks that have a heavy tumor load and folks that have, say, like my wife is post-surgery and she's NED right now on PET scan? Do you notice any
Well,
relationship?
there are two types of side effects. One side of it is, strictly speaking, side effects to the treatment, which make you feel not well. That's related, let's say, to treatment tolerance. And then there's immune reaction symptoms that occur. So there are two different types. And on the follow-up, what we work mainly is on establishing good tolerance to the therapy, so that that's not interfering with the continuation of your treatment, your compliance to your treatment. That answer your question?
Yes. I have another question.
Yeah.
Can you explain the difference between the dendritic vaccine and the vaccine that's produced using actual tumor tissue?
Well, they're the same, but the quality of stimulation is what. Well, let me put it this way. When we started using the dendritic cell vaccine, everyone got the dendritic cell culture stimulated with the circulating tumor cells in the blood. It was only over time that we improved so that tumor sample was now used to improve the degree of stimulation, but our treatment was doing well enough. Theoretically, if you have a tumor sample, if you have a fresh sample, then you can do a special type of cells, which are the what's called the tumor infiltrating lymphocytes, which is also an aspect of the immune therapy which is being refined. So there are several routes that our vaccine may be refined on the short term. Mm-hmm. So if you do not have a sample, if all we have is your circulating tumor cells, you can still expect to do well on the therapy, because the great majority of our patients over time have been people who've had their treatment based on their circulating tumor cells and not on surgical samples.
Thank you.
Okay, so to the last part of our therapy, the next most frequent question that a patient might ask is, doctor, are you gonna cure me in 12 weeks? Well, I told you two things during the course of this talk. One, high expectations are allowed. And two, a totally clean PET scan in the setting of multiple site disease, widespread disease, is not a rare occurrence at Oasis. A 100% response on a PET scan is not a rare occurrence at Oasis. Is well within the realm of capability for this treatment. So if we're talking expectations, you are allowed high expectations. However, avoid the pitfall. Doctor, my next door neighbor here had 100% response on the PET scan and I had 0%. That means the treatment's not working. Well, context. If you have a cancer, if you have a disease which was doubling or tripling every month or 2 or 3, and now after 3 months it stayed exactly the same, there's 0% of change, or even a slight change, adverse change, but not comparable to the rate of change that was happening before treatment. So, That's what we call evidence of benefit. We are hoping for the best possible response, but if we get evidence of benefit, if your cancer stopped growing after 3 months is a very long time for a cancer. It will grow or it will spread. If it did not, that's evidence of benefit. That's treatment related. So if it did not grow, we will score you as a positive. Because some cancers go away quickly, some cancers go away slowly, and some cancers don't go away at all. So if we have evidence of benefit, even if it's 0% change, that will justify the continuance of the therapy, such as it is, for as long as it may be necessary to continue the therapy to get optimal response. Again, some will go quickly, some will go slowly, and some don't go away at all. Does that mean that the treatment didn't help them? Well, some of our best examples of people who reached their expected life span, who lived to their expected lifespan, did so with cancer. They came to the oasis, they had a dire prognosis, and they survived to old age. And they died of old age. And they had cancer. So our main focus is not necessarily in getting rid of the cancer. Our main focus is to extend your life with good life quality, beyond the point of any expectation. Maybe even to normal lifespan, as some of our patients have achieved. And so that's the next best way that our treatment can help you, because obviously the best way is that the cancer goes away altogether. And if 5, 10, 15 years, you're back here and saying, I still have cancer, and you want your money back, you're not gonna get it. You're not gonna get it. Because again, our focus is that you live, that you extend your life, that you go beyond any of your prognosis. And that is something which is very, very much achievable in the Oasis of Hope therapeutic setting. Questions?
One,
Yeah.
you know, I'm here because my son,
Yes.
he's been fighting it for almost 8 years.
Yeah.
On and off and on. He's been in chemo 100 times and pills to control it, in and out. But his blood's always been almost like a typical normal person. If it wasn't for
His blood, you said?
his blood always, you know, even though through all those years, he was almost stable, you know, not, almost like a normal person. So,
Well, the reason for that is that it's likely that he hasn't been treated with cytotoxic elements, and right now we're still pending review of his history, treatment history. It may have been that he's been doing the target therapies, the immune therapies, which obviously don't carry that disadvantage.
and well, we taken care of food-wise since
That-
day one.
That's a big deal too.
And well, he's here still, but his tumors are the one that always knocks him down.
The best thing that you can say in such a situation is that judging by his history, he has a responsive cancer. You remember Dr. Contreras telling you you're a walking miracle?
Yes.
Well, lung cancer is a disease which carries a very poor prognosis, short-term prognosis. And he's been dealing with this for 8 years. So what conclusions can you draw? Number one, this is a responsive cancer. If it responded to all the other stuff, it will likely keep that characteristic of responsiveness. If it responded to all of this, it very likely will respond to our efforts.
Right. Like when I hear your story, 40 years or whatever, well, that's mainly what we've been through, you know. That's why we're here. Because I do have faith on you guys. All that experience.
Well, faith
comes in handy.
faith goes upstairs, but we do have a very strong treatment. And again, I want to underline in your particular case that we have yet to review the treatment history. And at the Oasis of Hope, we're not divorced from Orthodox practice. We're only divorced from it where we know it may not gain benefit for our patient. And there's a possibility that a late diagnosis in regards of crack in the cancer's armor is a possibility. And that way we would have a chance to do a two-front attack against cancer. So we're still looking to determine that.
Yes.
That would only improve the possibilities of benefit.
Yes. And,
Any other questions? Thank you very much for your attention. If you have any questions that you would rather discuss in the privacy of the office, feel free to request a visit with the medical assistants. Otherwise, we'll see you in rounds with Dr. Contreras.
Thank you very much.
¿Cómo se llama?
Cesena.
Cesena.